Good evening and welcome to Innovations in Breast Cancer Treatment. Happy Breast Cancer Awareness Month. I'd like to welcome all our guests who are here this evening. We have an exciting little program prepared for you, and I promise we will get to as many questions as possible at the end, but we probably won't be able to get all through them, but you can contact us, or we can get together for those questions that we don't get to answer tonight and answer them for you. So let me go ahead and begin the program. I do have a disclaimer to read to you regarding tonight's program, and just realize that the content is not intended to be medical advice directly to you, and the viewer should consult their physician should they have any questions. The viewer should not rely on information contained in this presentation webinar for immediate or urgent medical needs. If you think you may have a medical emergency, call your physician or go to the nearest emergency department or call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this presentation and webinar. This evening, we are going to be giving you a couple of presentations about a surgical procedure to improve how we can remove a tumor with clear margins. And we're also going to discuss some new and exciting treatment strategies for patients with estrogen or hormone receptor positive breast cancer that are not yet quite out in clinical trial, but are heading in that direction. So without further ado, I'd like to introduce the panel that's going to be presenting tonight. First, we have from our surgical oncology division within the department, Nazanin Khakpour, who is a breast surgeon extraordinaire, and she is the principal investigator of a clinical trial evaluating whether we can use MRI as a guide to more better and completely resect breast cancer for those having a lumpectomy. And she will go over what this trial is aimed at doing and what we do in it. Nazanin, please take it away.
Thank you, Dr. Czerniecki and co-panelists for this opportunity to share some exciting innovations in surgery at Moffitt Cancer Center. I am a breast surgical oncologist and have had the pleasure of being at Moffitt since 2008. And under recent guidelines, we are looking in this clinical trial to randomize patients to standard therapy, which is in patients that are candidates for lumpectomy, to have wire localization versus using some innovative methods of identifying tumors intraoperatively for better surgical outcomes. The device that we're looking at is called Breast Cancer Locator, and I think we can go ahead and forward to the next. Okay, I will move them. Thank you. The clinical problem we're trying to solve with this clinical trial is rates of positive margins after breast conserving surgery. Patients that are candidates for lumpectomy surgery can enroll in this clinical trial. And the reason why we have this trial is that currently margins are positive in about 20% of the time when patients undergo lumpectomy. Now at Moffitt, we have extensive multidisciplinary team of radiologists and pathologists that do intraoperative gross margin assessment of the tumors. And therefore, I believe our margin rates are positive rates are much lower than that. However, despite these efforts, we still struggle. The current localization techniques do not facilitate precise surgery. They tell us very little bit about the shape of the tumor, the three-dimensional location of the tumor, and the location of the tumor as opposed to the posterior or anterior aspects. The concept of this trial is using supine MRI, which is the position patients are located during surgery. And a 3D breast cancer model can be derived using a supine MRI because MRI will show us a very nice three-dimensional picture of the cancer as relationship to the surrounding tissue. The radiologist marks the tumor outline on each MRI slice and a 3D tumor model is constructed. Furthermore, the MRI is used to contour the breast. Next slide. As you can see in the first image, that's a breast image, and the yellow marking is delineating the location of the tumor in the breast and the outline of the tumor in this 3D model. Next. The serial axial slices are done to come up with the precise size of the tumor. Each slice is compiled and a 3D model is constructed. Next. Next. And this is a 3D reconstructed model of the tumor. As you can see, when we do a lumpectomy, the tumors are never a perfect sphere, and we don't just take out a circle. So we have to really understand the extent of the tumor edges as it approaches the normal tissues to make sure that we remove the entire tumor. Next. This is a complete three-dimensional picture of the tumor, which you can see how surgeons, by looking at just a simple MRI or a mammogram, can really not appreciate the three-dimensional picture, but this modality provides us very good visualization of the cancer. Next. There's an interactive visualizer in surgery, and this facilitates the surgeon to see the tumor precisely as it's located in the breast as patients sleeping supine. Some of you may have had breast MRIs in the past, and you realize that breast MRIs are usually done with the patient laying flat on their abdomen. That's not the normal position during surgery and operation. Therefore, this supine MRI helps identify precise location of the tumor as relationship to the pectoralis muscle as well as the skin. Next. The breast cancer locator is this device that is individualized per patient. After the MRI is done, the measurements that have made, there's going to be a hole where the nipple is located. And these areas that are shown on this device are actual location of the tumor, at which time the tumor is completely covered by these location of these holes, and the surgeon, while the patient's asleep in the operating room, can place wires, as many as 5 wires can be placed to completely remove the tumor with the most precision has ever been described in any other modality. Next. So the trial design, its primary objective is to compare the positive margin rate for women randomized to breast cancer locator versus standard wire localization of the breast. Remember, wire localization is done pre-operatively in radiology. Patients have to travel to radiology, have a wire placed in their breast while they're awake, and then travel to the operating room. Whereas the breast cancer locator also helps by having everything done in one step in the operating room under anesthetic, so patients' discomfort are minimized. The secondary objective is comparing specimen volumes, re-excision rates, cancer localization rates, needing for additional shape biopsies, operative time, any adverse events, and cost of care. Of course, any return to the operating room can increase cost of care, and the hope is that with this more precise method that we have less patients returning to the operating room, therefore decreasing cost of care. Next. The inclusion criteria, obviously, we're looking at women mostly for this device. Histological diagnosis has to be an invasive breast cancer or ductal carcinoma in situ. Currently, ductal carcinoma in situ is the one cancer that requires the most re-excision rates. Therefore, this is very important in studying in patients with ductal carcinoma in situ. Patients, tumors cannot be easily palpable by the surgeon, and the tumor has to be at least 1 centimeter and less than 2 centimeters. So these are for smaller tumors. The tumor enhances on prone breast MRI imaging, so it has to be visualized on the MRI and has to be also visible on mammography. And of course, a patient would be a candidate for breast conservation surgery and to be able to do informed consent. Next. So this is 1-to-1 randomization ratio. Once the patient agrees to do this trial, they are randomized by our coordinators and their consents are reviewed, any questions they have. Currently, there are 12 participating sites with 28 surgeons. Dartmouth, New Hampshire. Some of the other ones are going to be Mass General, the Women's and Infants in Rhode Island. And I'm proudly have to say that Moffitt Cancer Center has the highest enrollment rate of any of the centers. And we have to thank Dr. Czerniecki, even though I'm the PI of the project, Dr. Czerniecki has enrolled more patients than I have on this trial. Currently, we have accrued our 1 year anticipation earlier, but we are increasing our accrual rates. 18 months is anticipated. Next. And once all the patients, about approximately 440 patients are enrolled in the study, then we'll start looking at the data and we'll be able to present that hopefully at our next meeting next year, where we would have preliminary data on this trial. Next. The study is FDA approved, and there are data safety monitoring boards and research organizations, and Karen Surgical is a study sponsor. All the devices the 3D models are made outside of Moffitt and delivered to Moffitt Cancer Center sterilely, so we can use them in the operating room in eligible patients. I believe that might be my last slide. Next. Yes, thank you. Thank you very much for your attention. I'll be around and to the end of the program, be happy to answer any questions or concerns regarding this trial. Thank you for opportunity to present some of the exciting work we're doing at Moffitt Cancer Center. And that's all I have for now. Thank you.
Thank you, Nazanin. For anyone interested in this trial, you do get a lovely parting gift to go home with. You get to keep the locator that we use in the surgery. I have one patient that sent me a picture of her making it into a planter that she keeps in her house. The trial is actually very interesting in that it may have its best use in DCIS, where the MRI is a little bit more sensitive than calcifications on a mammogram, and it may help to complete the removal of DCIS more and facilitate that more in one shot than our current methods. So thank you, Nazanin. Next, we are going to talk a little bit about estrogen receptor positive breast cancer. For that, Dr. Aixa Soyano and I will sort of tag team this for you. Why estrogen receptor breast cancer? If you think about the history of breast cancer, the estrogen positive or hormone positive breast cancer is really one of the first breast cancers described. The treatments for it were some of the earliest targeted therapies ever developed for cancer. Tamoxifen is a specific anti-estrogen antagonist. And so it's an example of a medication that was developed now about 70 years ago for treating estrogen receptor positive breast cancer. Although it was the first to really target hormone receptor breast cancer, the other tumors, the HER2 and the triple negative, have passed it as far as all the different targeted therapies that have been developed. And although estrogen receptor positive breast cancer remains for the most part very favorable for most patients, there are some patients that do get recurrence with it, and it becomes difficult to treat when these tumors recur and spread, and they can actually recur even 20 or 25 years after the original removal of the tumor. So I was about 4 years ago, I was meeting with a group of patients at Moffitt that had metastatic breast cancer. And a group of them were estrogen receptor positive. And I was talking about HER2 positive breast cancer and vaccines and immunotherapies. And they asked why we didn't have an immune therapy for estrogen receptor positive metastatic breast cancer. So we took that to heart. And one of our other faculty at a retreat we were having said, why don't you just target the estrogen receptor with immune therapies? And I thought, well, that's kind of an interesting concept, but I don't know if it'll work. But it turns out that many of the patients that have metastatic breast cancer, their estrogen receptor mutates. And anything that's mutated in the body can become a potential target for the immune response. And so the topic of that, what we're going to show you tonight is how we may be able to use the immune system to target mutated estrogen receptors in patients with metastatic hormone receptor positive breast cancer. So I'm going to introduce Dr. Soyano, who's going to outline for you kind of the problem of metastatic breast cancer, and then I'll talk a little bit about what we did in the lab to find the immune response. And then she's going to describe for you 2 exciting trials that we're planning to do, hopefully by spring or summer next year. So Aixa, I'll turn it over to you.
Thanks, Brian. I'm so happy to be here sharing all this information with you guys. So if we can go to the next slide. So as we all know, breast cancer is the leading cause of cancer in females in the United States and globally, after more common skin cancers. And it represents the second cause of cancer-related deaths in the United States, and it causes about 43,000 deaths every year. So breast cancer is subclassified depending on those receptors that we know about: estrogen, progesterone, and HER2. And the hormone positive or estrogen progesterone positive HER2 negative is the most common subtype of breast cancer in the US. Next slide. So approximately 30% of the patients that have been diagnosed with breast cancer will have a recurrence or metastasize, and the most common ones will be those hormone positive HER2 negative ones. What that means is that the hormone positive breast cancer is fueled, or those cells are feeding off of the estrogen and progesterone that is in the women's body. And normally those hormones can attach to those cells. And if they're normal cells, they will have a normal growth. But in cancer cells, they will have this aberrant, disorganized growth. Treatment usually consists of some form of hormone blockade, but cancer, being a smart disease, eventually will develop a resistant mechanism to those hormone blockers to survive, and that will cause ineffectiveness in the treatment of hormone therapies. And a common resistant mechanism is the mutation of this estrogen receptor 1 that Dr. Czerniecki mentioned. And I will leave this to him so he can explain the problem a little bit more.
So there's a lot of tumors that use immunotherapies to treat them, and most of them have as a common theme that they induce, there's a lot of mutations induced in those tumors. For instance, lung cancer and cigarette smoke. Cigarette smoke is a significant carcinogen, and so it causes a lot of mutations in the lung that lead to tumor development. And it turns out in the medications that we use to treat things like melanoma and lung cancer and bladder cancer that have a lot of mutations, if you use an antibody to take the brakes off the immune system, it's very effective at eliminating the tumor. Breast cancer falls into the group that is not a very high mutation burden cancer. It's lower in the mutation forms, and as Dr. Soyano just pointed out to you, there's hormone receptor positive breast cancers, and then there's this subtype that's called HER2 positive, and then there's a smaller percentage yet of tumors that have neither HER2 or hormone receptors, and we call those triple negative. The very good, favorable estrogen positive tumors are what we call luminal A. Those are often found in patients. They're lower grade. They tend to have negative nodes. They can be very nicely treated with a lumpectomy. Those tumors generally do not lead to metastasis. A very small number of them will. But there's a group of tumors that are called luminal B that consist of anywhere from 25 to 30% of the hormone positive tumors. Those are a little more aggressive and can lead to recurrence. Now, when they can recur, if you advance the slide, patients are also at taking anti-estrogen pills, either in the form of aromatase inhibitors, which basically cause your fat cells or block your fat cells from making estrogen, and they're used in the postmenopausal women, or they're treated with tamoxifen, which is a estrogen antagonist, so it blocks estrogen from getting inside the cell through its receptor. Now, I mentioned that the ER tumors are the least immunogenic, and there's kind of a reason why that is. The immune system tends to ignore them. They don't have very many mutations in it, so it looks very close to the normal breast. So there's not a lot of immune cells in there, and the tumors themselves have found a trick to downregulate what the immune system actually sees on them. So they downregulate their receptors, so the immune system won't even see it, so it becomes invisible to the tumor. So the environment around these estrogen tumors is rather hostile. And so there isn't a strong immune response. Next slide. As a result of taking anti-estrogen therapies, about 40% of patients with metastatic breast cancer, that's ER positive, develop either a decrease, a loss, or they develop mutations in this estrogen receptor. And the mutation is basically a single amino acid change in the entire receptor protein. That's a very, very small difference. The other way they sometimes beat the anti-estrogen therapies is they use other pathways like HER2, one I mentioned before. We have therapies we can use at HER2 to help block that. So that helps combining HER2 therapy with anti-estrogen therapy. But tonight we're going to talk about the mutated tumors that have this estrogen receptor that's mutated. Next. So it's quite well known where these mutations occur. They typically occur in the estrogen binding domain. And in this red box here, you see there are 11 identified point mutations in the estrogen receptor that you can find in any patient that has estrogen mutations. The D538G, for instance, is one of the most common, as is the Y537 site. That just denotes which amino acid it is, number 537, that's changed from a Y to an S. So a single change. Now, the big question here is that single change enough for the immune system to see that protein now as different? Next slide. Continue. So what we did is we made, from all those 11 different mutations, we actually made a library of all the peptides in those mutations. And we actually even made a library against the native estrogen receptor. And we broke up these little peptides and we fed them to the immune system in a dish outside the body. And then we took a type of immune cell called the CD4 lymphocyte, and we co-cultured them with these dendritic cells or these antigen-presenting cells that are showing different parts of the estrogen receptor or the mutated estrogen receptors. And we ask at the end, do they now see this peptide or protein or mutation in the estrogen receptor? Because if they did, they will start secreting activators of the immune system. Next slide. So this is the example of the libraries from the peptides that we made of the native estrogen receptor. And if you look all the way over to the right-hand side of the screen, you'll see that there's a number P27, P93, P99, and P103. After we made all these peptides, those four were recognized by just about everybody that we took their immune cells from and cultured them in a dish, suggesting that these four peptides are somehow magically seen by the immune system in just about everyone. And so they could be a potential immune stimulant to drive an immune response against the native estrogen receptor. Next. And this is just a summary of the different donors, and we took patients that were participating in other trials, and we used some of their cells. And what you can see in here is a large percentage of these patients, both healthy donors and patients participating in clinical trials, some of which here have estrogen-positive disease, and they can actually recognize very well those four peptides. That's aim number one, is to find out that, yes, we can indeed drive an immune response against the native estrogen receptor. Well, that seems like a dangerous thing to do. Remember, the estrogen receptor in breast cancer is actually overexpressed compared to normal cells. It's abnormally expressed. It's super highly expressed, so we can differentiate, your immune system can differentiate the cells that have super high levels from those that have normal levels. And we were able to actually take this and compare it in mice. And in mice, they can recognize the same peptides. So it's going to allow us to test in animals whether if we were to give these peptides to an animal, will they generate an immune response? And I can tell you the answer is yes, and they can even fight ER-positive breast cancers. Next. So how about the mutations? Now we're asking, can a single amino acid substitution be recognized by the immune system? And so these are the 11 different immune responses, and this is their the peptide that's different. And what we did is we moved the mutation in where the immune system sees it. We either did it toward the beginning of the molecule, the middle, or to the end of the molecule. And then we asked the immune system, can you see these single point mutations from these mutated estrogen receptors against all these different mutations? Next slide. And this is a busy slide, but what it shows is you see the single red bars with all the black dots above them. That is telling you that is a strong immune response against most of these estrogen mutated proteins. So just a single amino acid change was able to drive the immune system to recognize that and secrete proteins that will actually kill tumor cells. Next. And this was also found in patients who had estrogen positive breast cancer. This is a group of patients who were being treated on a trial that we had some extra blood from, that we tested their ability to recognize these mutated peptides. And what you can see is, yes, they can very strongly distinguish that one epitope or one peptide mutation. And over here is a summary of, in the different mutations, how many patients could actually recognize them. And it's about 70 to 80% of them can be recognized. Next. So this is a summary of all the different donors that we looked at and all the different immune responses that were able to be generated against every mutation that the estrogen receptor has. And so to summarize it, the answer is yes, we can generate an immune response, a CD4 immune response that can impact a estrogen receptor mutated breast cancer. Next. And so what we're going to do with this, and I'm going to turn this back over to Dr. Soyano, is we can use this now to specifically target patients that have metastatic hormone receptor positive breast cancer, to use their immune system to attack these mutations. And it'll be quite an interesting specific vaccine that can be developed. We can transfer their immune cells and grow them out of their body and transfer them back. And we can also mix them with anti-estrogens and other therapies, CDK inhibitors. There's it's sort of a limitless possibility of using the immune system to help drive other therapies. Next. So we're going to go back and I'm going to turn it over to Dr. Soyano again. This is the group in my lab that helped to identify these mutations. Gabby here in the front has just started her PhD. She, believe it or not, did this as an undergraduate student from the University of Tampa, and she is now at the University of Colorado starting her PhD in cancer immunology. So Aixa.
Yes. Yep. So how do we take that data that it's built in the lab and how do we translate it into clinical use and clinical practice? And that's via clinical trials. So if we go to the next slide, we have designed two clinical trials for two different specific patient populations. So some of this hormone positive, HER2 negative breast cancer patients will develop what we call a local regional recurrence, meaning that they will have a tumor show up again in the same breast, the same axilla, or the chest wall. And why is that important is that, treatment options for this patient-specific population are very limited. They typically just involve surgery, but they represent a really high risk for developing metastatic disease in the future. So this is an area of very high clinical need because we need new treatment strategies. We need innovation to help cure these patients. And we know that, in these patients that already develop a local regional recurrence, they might have an ESR1 mutation in about a third of those because they have already been exposed to hormonal therapies. Next slide. So we designed a trial specifically for this patient, so hormone positive, HER2 negative breast cancer patients with a recurrence, where after they sign consent for the trial, they will undergo apheresis, meaning taking some of their own blood to manufacture this DC1 or dendritic cell vaccine. So that's a cell from the immune system that presents the antigen. So it's kind of like a police of our white blood cells, and we'll create a vaccine. In the meantime, they will also be treated with hormonal therapies. And as Dr. Czerniecki said, the possibilities are endless there. So those patients will be vaccinated against the native and the most common ESR1 mutation receptors. And they will do that for about 4 or 6 weeks. In that period of time, we will also get some blood draws and we will analyze what's happening to the immune system of these patients as they're getting the vaccines and how they're responding to the vaccines. And they will eventually end up having their breast cancer surgery to remove their recurrent tumor, and they can get booster vaccines afterwards. Next slide. The other trial that we've designed is a trial focusing on patients with hormone-positive metastatic breast cancer that already have a known ESR1 mutation. We typically can come up with this via a genomic test, which is a simple blood test or a test on the tumor or from a biopsy from one of these metastatic sites. And it will include patients that have had endocrine therapy before, so some of these hormone blockers, and up to 3 lines of chemotherapy. So similar to the previous trial, they will undergo leukapheresis to create their vaccines. And we will give them fulvestrant, which is a medication that helps break down estrogen, so that will help the immune system see and recognize some of these tumors more clearly. As the patients are undergoing their vaccine treatments, we will do a blood draw and we'll isolate this other types of white blood cells called the CD4 T helper cells. So it's kind of like a different army. So we will take them out, we will grow them, expand them, and give them back to the patients, kind of like giving them a re-educated army or police to help break down all these tumors. And then the patients will be analyzed and monitored to see how they respond to these treatments. Next slide. The goals and the objectives, these are small safety immunotherapy trials that are usually not available for these patients because we know that it's been hard to develop an immunotherapy trial in this population. But it will allow the researchers to look into their patient's tumor, their lymph nodes, their blood, look specifically at the CD4 T cells, the B cells, and antibodies against this estrogen receptor, and will allow us to study the ESR1 mutation to help tailor more vaccines in the future. So it opens possibility for many patients in the future. It will also help us study some preliminary efficacy and apply immunotherapy for this patient population. Next slide. I think that was the last one.
Thank you, Aixa. I just wanted to reiterate to the group listening in that these kind of clinical trials often have been funded by donors to help move them along quicker. We've applied for Department of Defense money. When you apply for grants like that to do these kind of trials, it's sometimes a year or 2 years by the time everything gets approved and it gets through the government and you're allowed to start the study. We had such a trial in triple negative breast cancer last year, and we were able to use funds from the Shula Foundation within our breast department to actually be able to move that clinical trial up for patients with triple negative breast cancer, where we're treating them before they start chemotherapy. That trial is about to start. And we also were able to fund from donations made to the department a clinical trial for HER2 breast cancer, where we can use the immune system to replace chemotherapy. We're actually reducing the amount of chemotherapy that patients with HER2 breast cancer can get, and we're combining it with Herceptin and Perjeta, which are HER2 targeted agents. And that trial is about to start within the next week or so. So that deadline got moved up probably about 3 years from having to wait to get approvals for that by us using Philanthropy and donor sources of money to actually pay for some of these clinical trials. So the same thing could be true of this anti-estrogen trial that Dr. Soyano described tonight. We're hoping that maybe we can get this moved up if it's funded through private sources. So I want to introduce our leader of Philanthropy and Support for the department, Carolyn Bean. And she's going to discuss a few things with you, and then we will get into some questions for the group. I know everybody's got questions about how some of these trials work and different kinds of breast cancer. So Carolyn, I'll let you take over, and then we'll reconvene the panel for audience questions and answers.
Thank you, Dr. Czerniecki. Just wanted to come on very quickly to introduce myself and thank you all so much for joining us. We have nearly 100 individuals on the call today, so I hope you all have found this chat informative as well as inspiring. One of the things that I enjoy so much about the opportunity to get to work with Dr. Czerniecki, Soyano, Khakpour, and the rest of the breast faculty is hearing about everything that's coming in breast cancer research and the passion that they have for treating their patients now, as well as their patients in the future. And it really provides a lot of hope for the future of care, as well as care right now for our patients. As Dr. Czerniecki mentioned, philanthropy can really help accelerate the rate at which they can complete this research. So if you are interested in any capacity in any way and in getting involved and giving back, please reach out to me. My contact information is included on the slides, as well as your registration emails. So I'd love to work with you and find a way that we can partner together to help give more patients hope for the future and change the future of care. So thank you all so much, and I will turn it back over to the panelists for the Q&A, which I know everyone is quite excited about.
We did request, or some people submitted questions about various breast cancers, and what I'll do is, Stacy, if you can put them up, I'll start to ask some of the panelists. I'm going to pick some of them out randomly and ask some of the panelists. I know there's some questions coming into on the chat that some of you are responding, or some of the panelists are responding to, but let me get the questions that people asked before. Okay, so I'll take question. One of the questions is, how far away are you from having a cure for breast cancer? So that's a kind of a loaded question, because it means that, are we talking about prevention from people from never getting breast cancer in the future? That's a possibility, and that's something that is probably a good 20 years away. A cure for those with breast cancer, I think we're much closer to that for some of these diseases. For instance, HER2, the majority of patients used to die of that breast cancer. Today, it's a minority, and it's shrinking by the year. And so for some breast cancers, the answer is going to be maybe within the next decade. For like ER positive breast cancer, we're probably a little bit further away, but the trials that Dr. Soyano proposed tonight will be a step in the right direction there. Aixa, you have any comments on that?
Yeah, I mean, same, it's a question that has many answers, but, you know, as opposed to different solid tumors or even blood malignancies, we do cure a lot of patients with breast cancer with the current therapies that we have, and we're just trying to focus on those that we have not found a cure yet.
Let me ask, a patient's asking, I have triple negative metastatic breast cancer. Anything new on that front, Dr. Soyano?
Yeah, so there's a lot of work in triple negative breast cancer. We had a new drug being FDA approved last year that have completely changed how we treat some of these breast cancers and decrease toxicities. And there's a lot of work in looking at targeted therapy. So similar to the concepts that we were talking about with the ESR1, but looking for different mutations in triple negative breast cancer. So more and more drugs will come along.
let's see, we have a patient asking if she can get in the MRI trial. Nazanin, can you explain how she can get enrolled in that trial?
Yes, I believe she's your patient, Dr. Czerniecki.
Yeah.
There's a select criteria for this. As I mentioned, the tumor has to be not palpable. Exactly, you can have part of the tumor you can feel, but if you cannot delineate the exact margins, there's definitely, I saw your name and I'm going to review that with Dr. Czerniecki to see if you're a candidate. We're enrolling patients in this trial, and right now we have enrolled the most of any other centers at Moffitt. So we're looking for eligible patients, and I'll definitely discuss that with Dr. Czerniecki, and we can see if you can be a candidate for that.
Let's see what else we have. How do you decide whether to do a lumpectomy or mastectomy, Nazanin?
That's probably one of the most difficult decisions patients go through. I know sometimes we talk about chemotherapy, and I work a lot with our oncologists, and I was in clinic today and I didn't really even discuss surgery because I felt that patients should do chemotherapy up front. But I promised her we would discuss surgery, and this is a very difficult decision for some of the patients. For patients that have solitary tumors that is located to one location of the breast that can have a good cosmetic outcome with the lumpectomy, we always offer that option because now more than 60 years, we know that lumpectomy followed by radiation can provide patients with excellent outcomes from both survival as well as low recurrence rates, and they're comparable to a mastectomy. So we present patients their options, and some of it is driven based on patients' genetic profiles, or if they have what we call multicentric breast cancers or other things that may not make them a good candidate for lumpectomy, then we'll discuss mastectomy. Certainly, all of our surgical members at Moffitt review patients' options with them, because in addition to looking at the pathology of the tumor, we look at the imaging and try to make sure that we have given them all their options.
Thank you. That's always a challenge. A couple of facts that I think people mix up is that if you do a mastectomy, you don't have a breast anymore, so you shouldn't get recurrence, and that's not exactly true. In fact, the survival difference in between a lumpectomy and a mastectomy is pretty much equal for most tumors. And the other thing is recurrence rates are very similar between mastectomy and lumpectomy too. A lot has to do with the biology of the cancer. Let's see what else we have here. If all goes well with the trials, what would be approximately the time frame to see these vaccine type options available? Aixa, you want to handle that?
Well,
I assume they're talking about the ESR1 vaccine trials that you were mentioning.
Yeah. I mean, it does take a lot of time for these vaccines to develop, because what we typically do is we do a small phase 1 trial that we try these vaccines in a few individuals. And then if all that is successful, then we go to a phase 2 and we expand it. So it takes a few years for that to actually be available, but there's a lot of back work already done that will facilitate these vaccines to enter, a commercial space in the next few years.
Yeah, I'd echo that, because we would do an initial trial just to establish whether it was safe to give immune responses against those mutated receptors or the native receptor, and then we'd have to do some larger trials over there to confirm if they're effective or not. And so all that does take some time, and so the average drug from development is on the order of 10 to 20 years to get from development into approval. So it will take some time, but the progress is moving along, and the FDA is getting much quicker with their breakthrough designations because they understand people with cancer don't have time to wait. I'm going to go back to triple negative. So we've got a couple of triple negative questions again. And one of the questions, do we have any suspects for receptors or drivers of triple negative breast cancer? And why is the prognosis for triple negative worse than the other types of breast cancer? Aixa, you want to handle that?
Yeah, I think, some people consider like a triple negative to be like a bad misnomer because we just haven't found a targeted endpoint to develop these drugs into. So I think that's why, because we cannot target it with hormones, we cannot target it with the monoclonals for the HER2, then all we have for treatment options are chemotherapy and all the toxicities associated with it. And triple negatives tends to be, despite chemotherapy, an aggressive type of cancer. But there are, newer forms of chemotherapy, antibody drug conjugates have been developed. So I think, the triple negatives are late in the game, but they will get into a better prognosis. Just as the HER2 was a horrible, type of breast cancer 20 years ago, and now has a much better prognosis, I think we're just heading into that right direction.
I will add to that and say that there are drivers that are known on triple negative, and we have a trial of an immune therapy that's actually targeting one of these receptors right now, and it's called HER3. It's a relative of HER2, and there's another receptor called HER1 that's a relative of HER2 that it's also epidermal growth factor receptor, which is highly expressed on a lot of triple negative breast cancers. So most of the triple negative breast cancers have either a hepatocyte growth factor receptor, a HER3 or a HER1 driver on it. They also have mutations in P53. So there are plenty of suspects and there are plenty of drivers for triple negative. There's even some suggestion that triple negative is sculpted out of the real resistant cells from the immune system, that most breast cancers start out as ER positive or HER2 positive. And then if the immune system sort of nibbles away at them, the tumor is allowed to fight back and it uses some of these other receptors to maintain itself. So you're going to see some clinical trials. And in fact, one that I suspect will start in the next couple months in our group, where we're actually vaccinating against one of the receptors called HER3 on triple negative in both brain metastasis and for neoadjuvant therapy before chemo. So that's a good question. There's another question here. 32T. This sounds like it's a HER2 breast cancer question. ER, bilateral mastectomy, Herceptin, Perjeta, Lupron. My new oncologist recommending Nerlix ASAP. Do you recommend this for people with my markers? If so, what's the time period between ending Herceptin, Perjeta, and starting Nerlix? You want to comment on that, Aixa?
Sure. I mean, the trial that proved that Nerlix was beneficial in these patients, they started the Nerlix after they finished their Herceptin. Now, at the time that this trial was designed, Perjeta was not typically used adjuvantly like you had. So we don't really know what the real benefit of doing Nerlix after Perjeta is, like if the benefit is going to be really good or it's just average. Now, you being 32, with a HER2 positive breast cancer, I would definitely consider a discussion about doing Nerlix, but it should be started after you're done with your Herceptin.
How about Kadcyla in that setting? That indicated?
Yeah, so I mean,
it sounds like she didn't have neoadjuvant. It looks like she had.
Oh, okay.
It looks like stage 1.
Okay.
I don't know if she got treated first with chemo or after her surgery. I'm assuming it's after, since this is stage 1.
All right. So Kadcyla is used when patients have undergone chemotherapy before surgery and they still have residual disease or cancer that was not completely killed by the chemotherapy that's found after the surgery. We don't typically use Kadcyla if the patient had surgery first and did Herceptin Perjeta chemotherapy combination.
Okay, thank you for that. Let's see if we have any other questions here. There was somebody who asked, what is the best way to find out about what clinical trials are available at Moffitt? Aixa, you want to explain how people can find those clinical trials?
Yeah, so if you log into the Moffitt webpage, moffitt.org, you can actually look what clinical trials and in which department you're interested or what type of tumor you're interested, and it will list all the available trials that we have running. Another option, if you want to look into clinical trials across the US and even worldwide, you can log into clinicaltrials.gov. That's where all clinical trials get registered. Sometimes it's a little bit cumbersome because there's a lot of information there, so you have to use keywords to kind of get to the area, but you can see what other trials are available at different institutions as well. So sometimes it's about sitting with your oncologist and trying to figure out what's best for you, but if you're interested at Moffitt, you can go to the Moffitt webpage.
Another question somebody asked is an interesting one because a lot of people get this confused, but we keep hearing that if you're cancer-free for 5 years, your recurrence risk is minimal. Is that true? Nazanin, you want to comment on the difference between triple negative, for instance, and ER positive about the years free of recurrence? I think you're muted.
Thank you. I tried to answer as many of the questions as possible as I was listening to your and Aixa's presentations. I think generally speaking, we have sort of sometimes a false reassurance that, okay, 5 years is a great milestone and no cancer recurrence can happen after that. Now, I have been at Moffitt about 14 years, and unfortunately, I've experienced recurrences in our patients that have really were treated initially when I first came to Moffitt in 2008. So you stay in a place long enough, you see your own patients have recurrences. Generally, at Moffitt, we do have a survivorship clinic where patients after 5 years can, who are not in any active therapy, can go for their routine cancer surveillance. So why do we use the 5 years? Because of all the patients that recur, 90% recur within the first 5 years. So there's still a small group of patients that can recur after that. And that's why these trials are important once the treatments are completed. And I'm talking about 5 years after the completion of all treatments, whether it's chemo, surgery, radiation. And so some of these endocrine therapies, anti-estrogen therapies can now be recommended to go beyond 5 years, 7 years, 10 years for some high-risk patients, because we do realize that some patients can have recurrences. What is immunotherapy and vaccine trials? What we're talking about is that we can then provide your body with the immunotherapy that it can fight any recurrences further down the line. And that's the whole excitement about immunotherapy. And Dr. Czerniecki's research has shown that if we can, in addition to the standard treatments, provide patients with some immunogenicity, then we can provide longer term better outcomes as far as lowering the risk of recurrence. So this work is very exciting and it's really cutting edge medicine. That's what's the next step in, what's individualizing patient cares to the molecular levels, to the biology of the tumor, to provide them best long-term outcomes.
Okay, thank you. Someone asked, are the immunogenicity studies applicable to both lobular cancer and ductal cancer? The answer to that is yes. mutations happen in lobular cancers, which are usually ER positive, and people are on significant anti-estrogen therapy for longer periods of time. And so there are estrogen receptor mutations in both lobular cancer and ductal cancers. Let's see, maybe we'll do one more. What work is being done on reversing hereditary factors like BRCA or CHEK2? So I don't know if you mean reversing or if you mean what's being done to try other alternatives besides prophylactic surgery. Aixa or Nazanin, you want to comment on that?
I mean, I agree. I'm not sure what the question is, but there is a lot of work being done on treating these patients that have, a genetic mutation that predisposes them to them. So if they do develop cancer, they do have other treatment options available that are specific for their mutations.
I would agree, but BRCA mutations now have some specific drugs that are available that help them more specifically. I will say, as far as immunotherapies, we are working on some preventive vaccines for BRCA. We haven't delved into CHEK2 yet, but for BRCA, their DCIS has some different markers on it than the more common DCIS. Some of them already going into trial for triple negative breast cancer. HER3 is one of them that is richly expressed early on in the BRCA mutation tumors. And so one day we hope that there'll be some alternatives that if we can boost their immune response against some of these drivers of these cancers, that there'll be alternatives for prophylactic surgery. But as of yet, prophylactic surgery remains one of the stronger ways to reduce your odds of getting breast cancer. So the hour is late. I think I want to thank the panelists who are here tonight, Dr. Muller and Dr. Khakpour. I want to thank Carrie and their team for putting this together. And I want to thank especially all the participants who tuned in to listen to this panel this evening. And again, if you have specific questions or want to get involved or want to help support breast cancer research at Moffitt Cancer Center, please get in touch with one of us or Carrie, and she can help to move these things along quickly. So again, thank you for your participation, and I wish you all a good evening as we continue Breast Cancer Awareness Month. Thank you.
Thank you. Good night.